Well, hey everybody, my name is Mary Coughlin and welcome to the Protected Sleep Module number 3, where I'm going to talk about sleep in the NICU. I'm going to specifically talk about sleep with regard to the patient and regard to the parents. I think sometimes we don't think about sleep, and often we misread sleep. We think the baby's eyes are closed, so they must be asleep, but really being able to distinguish whether the infant is asleep or unconscious is really a key aspect of assessing where the patient's at. Are they overwhelmed by their environment, or are they in an optimal state of sleep? And then using that information to inform what's our next step, right? If they're in an optimal state of sleep, maybe we can go do up somebody else. Maybe we can wait a little bit before we do non-emergent caregiving. If the patient's eyes are closed and you think that it may be a response to being overstimulated or too much pain and stress, then obviously you can then take the next steps to mitigate that stress and distress and be more responsive to the infant. But it's important to be able to tell the difference, right? I mean, I just thought their eyes are closed, they're asleep, but nothing could be further from the truth. To kind of kick this off, I just want to set the stage with this really interesting physiological representation, graphic representation from Bennett et al. That really talks about too soon, when babies are born too soon, and how that really undermines the optimal developmental trajectory of their sleep architecture, which is, a reflection of brain integrity and intactness. And it begins right at that premature birth. So we know in an optimal healthy pregnancy, different neuropeptides, neurohormones, and other types of biochemical mediators are transferred back and forth via the placenta that help the baby entrain to diurnal rhythmicity or circadian rhythm of the mother, and also facilitate the transfer of nutrients and other types of mediators to optimize the growth and development of the infant. Once that is severed, once premature birth and even full-term birth occurs, there's a whole new ball game happening, right, for these individuals. The placental hormones for the premature person are now no longer available to this infant, and depending on the level of immaturity, this infant may not have what they need to foster the ongoing neural development that needs to happen for them to, progress to to optimize their developmental trajectory as identified by the genetic blueprint and all that kind of stuff. So being mindful that when we're able to protect and preserve their sleep, we're actually preserving and protecting brain development. Protected sleep is neuroprotection. Babies spend the bulk of their life, right? They're 24 hours in their day. The majority of that time is spent asleep. And so during that period, there's a lot of growth and development actually going on. We know when premature birth occurs, there's delayed maturation of the sleep architecture. We see a reduction in glial and neuronal cell production and maturation, impaired neural connectivity, and impaired neurotransmitter function. And again, these guys are kind of trying to figure out, now that we're on our own, so to speak, right? We're outside of the uterus, we're immature, we're premature. How are we going to optimize? And so some of the long-term consequences that you see are, secondary to that disruption of that developmental progression. Our job is really to minimize any confounding injury that can further delay or impair their development. Both, physiologically and neurologically as well. Sleep development is affected by a variety of different things: gestational age, as I mentioned, growth restriction, and inflammatory processes. Inflammation can really wreak havoc through oxidative stress and other types of biochemical processes, can undermine the developing brain. Primary brain injury can also add insult to injury, if you will, in the development of sleep architecture. And again, optimal sleep-wake cycling is really a reflection of brain health and wellness. And so when we see alterations in sleep, not just in infants, but in young children, adolescents, and even grown-ups, there's usually other types of underlying pathologies associated with the sleep perturbations. And it's kind of one of those chicken and egg things. Sleep deprivation and disruptions in sleep can negatively impact health and development, as well as altered health states can also negatively impact the development of the sleep architecture. Apnea, sleep positions, all these other types of things are referenced here in the graphic. It's an excellent paper, and I strongly recommend that you read it. Reduced sleep quantity and quality then is a consequence. And I'll talk in the next slides about how much time these individuals spend in sleep. But the longer term outcomes of sleep deprivation, as well as toxic stress, unmanaged pain, separation, all of the things that I talk about with regard to trauma-informed care. It impairs learning, memory, and cognition. These individuals can go on to have behavioral and emotional problems, as well as psychomotor problems and sensory integration problems as well. All as a consequence of sleep deprivation or disruptions in the normal developmental trajectory of sleep architecture. So, if you look at this graph, you can see that the green is awake states, the blue is the non-REM, and the red is the REM sleep. If you look at the dotted line, the vertical dotted line, that really represents birth, full-term birth, all right? So full-term individuals, 40 weeks gestation, spend approximately 50% of their sleep time in an active sleep state, and that active sleep state is kind of like an immature version of REM. And the other half of their sleep time is spent in quiet sleep, which is an immature form of non-REM sleep. Sleep cycles always begin with quiet sleep or non-REM sleep for adults or mature individuals. So it starts with a quiet sleep, then it transitions to active sleep, and then there's an opportunity to either awaken or go back into a quiet sleep. And these cycles go on around between 60 to 70 minutes for each full cycle in infants. But what I want to really draw your attention to is in this graphic, the majority of the sleep time, the more to the left of the birth line you are, right? The more immature you are, the more time you spend in active sleep. There's lots of brain maturation occurring during active sleep. Neurosensory ordering and development occurs during active sleep. Lots of neuronal migration, glial migration, I mentioned that on the previous slide, occurs during active sleep. And what I want you to observe is that the amount of active sleep that happens diminishes over time, right? So that by the time you're into an adulthood, you're spending a very small percentage of your sleep time in active sleep or REM sleep, right? Because REM sleep once you hit around 6 to 12 months of age. And so you're not getting that back. So what I'm trying to say is that the things that are supposed to be developing and being organized and myelinated and all these activities that are supposed to be happening during active sleep, if they don't happen, that's it. It's all over and done with. It's not coming back, right? So the reason why this is relevant for us as clinicians, particularly folks that take care of predominantly premature individuals, is your responsibility to really preserve that active sleep as much as you can, to really protect the development and the organization that is happening during active sleep. Ideally, I want you to preserve all sleep. But if you're in a situation where you have to make a choice, I would urge you to protect the active sleep as much as possible. By the time these individuals are term and it's a 50-50, I mean, I would lean towards active sleep, although there aren't any articles or studies that really tell us, you know, if you compromise one over the other, what happens. But again, just, you know, if you can wait for a wakeful state, that's the best. If you're not able to wait for a wakeful state, then what I would encourage you to do is choose quiet sleep if you can. This is non-emergent care. Before you begin the cares of the patient, before you flip them over and start doing all the activities that you need to do to check off your list, put your hands on two non-vulnerable areas of the infant, you know, the crown of the head and maybe the lower extremities. Give the baby a verbal greeting and then that tactile greeting. What that does is it rouses the baby, right? Rouses that baby from that sleep state so that they can become aware of your presence. Think of yourself. You're sound asleep, snug underneath the covers, and somebody walks into the bedroom, flips on the lights, starts playing loud music, whips the covers off you, and wakes you up. Think about how that feels, how shocking and disruptive that is. That's a lot of what we do to these critically ill babies who don't have the reserve to handle that kind of alarm or distress. So again, being gentle, helping them rouse to a wakeful state is really the recommended way of beginning your cares. And it also helps you get an assessment. You can get your respiratory rate. You can really kind of see what the level of comfort is for the baby and these sorts of things. So, it's advantageous on both sides of the coin. This is just another graphic kind of giving you a more colorful representation of the progression of active sleep to quiet sleep from 28 weeks gestation to 1 month post-term. Active versus quiet sleep in neonates at 28 weeks is the predominant sleep state, versus when you look at them at 1 month, you can see that now quiet sleep is starting to take over. And what happens with quiet sleep as it matures, it differentiates into the 4 different levels of non-REM sleep, right? And where level 4 is your deep sleep, not REM, but your deep sleep. So just to kind of help you understand the progression of sleep. And then I'm going to refer you back to module 1, where you really understand the important role of sleep. This isn't something to be taken lightly. Yes, I understand these individuals are in a life-threatening situation, but our first admonition is to do no harm. So protecting and preserving sleep, as well as adopting care strategies that support sleep, is really a best practice. So we talked, in module 2, we talked about sleep in the clinician. This module, we're introducing sleep with the infant, but also sleep with the parent. And I want you to just harken back to some of the things that I shared with you about sleep in the clinician. Most clinicians are adults. Most parents are adults, although I know there are some adolescent parents. And understanding what the sleep needs are of adolescents is a really important factor for NICU clinicians to really support the whole family unit's health. Adolescents in general need between 9 and 10 hours of sleep, just general. Never mind when they are in a postpartum situation or in a crisis situation. So being mindful of those principles really is key. Overall, mothers with hospitalized preterm infants experience disrupted sleep, high fatigue levels, and severe insomnia. Fathers also experience some significant sleep disturbances, as well as other partners to the family. There's been a series of subjective sleep studies really examining the impact. Most of them are really focused on the mother. There are a few studies that you'll see on mothers and fathers, but the takeaway from these studies is that whatever their basic sleep health was as a pre-existing entity to their NICU experience, right, that then is kind of blown up in response to the NICU experience. So if they're not good sleepers at baseline, they're going to be even more horrific sleepers as a result of this crisis that they're enduring. Because we know when you are in crisis, you're wound up, you're in an HPA axis activation, you are in a stressed state. And stress does what? It disrupts your ability to sleep. Throw into the mix the fact that now they're creating this whole new routine in their life, right, around coming to the hospital, managing whatever stuff they've got going on at home, whatever the job situation is. All of these kinds of factors now have to get jostled around and fit around this acute event that the family is now dealing with. And oftentimes, sleep takes a back seat. And what we know, when sleep takes a back seat, it actually increases the risk for emotional and mental health disturbances, disruptions, and even pathology. We know that NICU nurses are uniquely positioned to provide care to both mothers and neonates during this vulnerable time. So we really need to be informed and understand from a holistic perspective, how can we support this family in crisis? And certainly diet, exercise, sleep play a prominent role, as well as knowledge and empowerment and all those other kinds of things. Mothers who birthed by a cesarean section experienced shorter total sleep time, and in this meta-analysis, the authors highlighted that the majority of low birth weight infants were born by cesarean section. So you've kind of got this like double whammy with these moms that are being delivered by C-section, so they're already going to have a reduced sleep time. And the reason for that is multifactorial. Whatever their pre-existing situation with sleep is kind of underpins this. but the pain that they experience, incisional pain, the mental anguish, the distress, all that other kind of stuff, pumping needs, all these other types of things are going to all be a factor in the quality of their sleep or the lack of quality of their sleep. The NAN, which is the National Association of Neonatal Nurses, recommends that moms of preterms express their milk 8 times daily and at least once at night. So you've got that pressure on top of the distress and angst of, whether their child's going to survive, what are the long-term consequences, all of this stuff is going on. And so, having mental health resources for the family is really key. Also speaking to them really plainly about how they can support their own sleep hygiene. Having mothers or parents be able to sleep at the bedside in kangaroo. And now, of course, as I'm advocating for that, you also have to have the safety net in place, to allow mothers to sleep and parents to sleep safely at the bedside. So making sure that you have a safe wrap where that baby is going to be secure. You have the proper seating. You have the proper monitoring available. All of these different aspects really have to factor in. But it's incumbent on you to figure out what that's going to look like. And again, as I've said in all of the modules and all of the teachings, you have to test things out and see what's going to work best in this situation, giving whatever kind of constraints and resources we have. Test it out, but you got to think outside the box. The provisions of maternal milk for preterm infants must be a priority. However, sleep deprivation is going to really undermine milk production, as does toxic stress and the crisis that the family is experiencing and all of the other competing priorities that have this family completely freaked out about what they're dealing with right now. The design of the NICU and the human environment and how it influences sleep. So whether you're an open bay unit, pod style, single family rooms, what is the lighting? What is the acoustic situation in that space? What is the workflow, right? Are you in the private room, but it's right near the entrance and it's really, really busy? How do you manage that? Again, protecting the sleep for the infant and the family is really, really key. We know that there's an acoustic gap between the NICU environment and the womb experience of the infant. And from an adult perspective, we know when you review HCAP scores, those are patient satisfaction surveys that we do here in the US, and I believe you do some version of that in the UK. One of the chief complaints of patients is the difficulty they have in sleeping during the night because of disruptive routines, because of loud voices, because of lighting and stuff like that. So, I'm looking at the infant right now on this slide, but I want you to also appreciate the bigger scope of the environment and how it can also impact the parents. The primary mode of sound waves in utero is through bone conduction, which is through fluid, versus air conduction. And so the fluid and the bone conduction actually protects those inner hair cells, right, in the inner ear. It protects them from exposure to high frequencies that can damage these developing structures. But once they're born into the NICU, those high frequencies can actually cause damage. And we know that a lot of our patients experience some forms of either hearing loss or auditory hearing impairments as a consequence of the environment. We also know that language skill acquisition is occurring, right, in the prenatal and the postnatal period. And so having an environment that allows for vocalizations, parental vocalizations, and that transfer of language to the infant, whether it's by storytelling or singing or those kinds of things, are really, really important. The most significant sound in the environment, I know you might think it's the alarms, but it's actually us. It's the people in the space. We can actually modify our sound levels. A lot of the equipment, the alarms are set at a certain sound level because of the life-saving nature of the alarm, but also being mindful of nuisance alarms and how can we attend to them in meaningful ways so we really can keep the overall sound environment within the recommended range and protect the sleep of the inhabitants that way. This was a really interesting secondary analysis of some data looking at hands-on care in the NICU and sleep. And what they discovered was that it didn't matter what sleep state you were in, if you were asleep or awake. If it was 8 o'clock, it was 8 o'clock and you were getting done up. And so it just really highlighted a knowledge gap with NICU nurses around the importance of sleep, how to assess sleep, and maybe pacing cares we talk about cue-based care. Well, sleep and wake are cues. And so how do we use that to protect sleep, right? Obviously, we have to get our work done. I recognize that. But, the risk-benefit ratio needs to be analyzed, and the patient should win. It's not all about us. It's all about them. What was interesting is, so not only did they discover that the majority of sleep happened when the infants were asleep, the majority of the cares were performed when the infants were asleep, but that actually doing the cares during a sleep state precipitated a respiratory event. And in the paper, they identified hypopnea, right, lower respirations, apneas, absence, and desaturations. And you can see in the first column, the number of contacts when the baby was awake was 173, and the very low incidence of inducing a respiratory event. However, when the sleep was an active sleep, remember that immature REM sleep that I mentioned earlier, 171 of the contacts occurred during active sleep. And look at the statistically significant increase in the frequency of hypopnea, apneas, and oxygen desaturations during that sleep state. And then as well as quiet sleep. Indeterminate is the transition stage between active and quiet sleep. And so you can see that also is a vulnerable period, but the most vulnerable is during active sleep. So again, once you're informed and you're armed with this, it's an invitation to do better and a responsibility to do better as well. And so you might be thinking, well, gee whiz, how am I supposed to know if the baby's asleep, and let alone what state they're in? And so I got to work with some really cool clinicians, and we reviewed the literature and identified the behavioral expressions that were correlated with the two different sleep states. Well, and then wakefulness, right? And we developed what's called the Neonatal Sleep-Wake Assessment Tool. The indicators that have been demonstrated through polysomnography, EEG, to represent sleep are the status of the eyes, the respiratory status, facial expressions, and motor activity. And so when the lids are closed and you can actually see rapid eye movement, the eyeball moving behind the lids, that is, the baby is in active sleep. If the lids are closed and you don't see that, the baby could be in quiet sleep, and you want to progress down to the other indicators. In active sleep, respirations will be uneven, not dyspneic, just uneven. And you might see some belly breathing, you might see some kind of seesaw breathing, versus regular respirations, very smooth and rhythmic respirations are often associated with quiet sleep. During active sleep, you also may see the infant make some, different faces, and they may pucker up and make frowny faces. They may cry a little bit. And so when you see that, again, you're making an assessment. You don't know, are they waking up or are they in active sleep? Just wait a second and you'll see the progression of where they're going. Versus in quiet sleep, the baby's face is quiet. You don't see any of these types of movements. You have nice tone and just a quiet face. And motor activity. So again, for active sleep, and you guys may have experienced this when you sleep yourself. Have you ever woken yourself up by kicking your leg out from underneath the covers, or some kind of erratic movement? Often happens during active sleep. During the dream sleep, right, which is REM sleep. And again, are they waking up, or is this an evidence that they are in active sleep? Versus quiet sleep, the baby will have that nice soft flex tone, but no movement at all. And then awake is awake, right? They're moving, their eyes are open, they're interacting, and you know that they're awake. So it's a neat little tool to help you learn. This is not for, to make your life more miserable with documentation. This tool was designed as a teaching tool to help you recognize what sleep state is the baby in, and then you can make the decision. Do I need to do cares now, or can I wait? Because when we don't wait, when we go in, not only are we eliciting respiratory events and disrupting their sleep, but there's a whole other cascade of neurobiological consequences that are affiliated with sleep deprivation / sleep fragmentation in the NICU. We know that babies, the younger you are, the more time you spend in sleep. So full-term people, they sleep about, it's like 14, maybe 11 to 15 hours a day, full-term people. The younger you are, the more time you spend in sleep. And so up to like maybe even 21 hours a day in a 24-hour period, as I said, they sleep in cycles, and you'll wake and then go back to sleep and wake and go back to sleep. But their total sleep time could be about 21 hours in a 24-hour period for the very immature people. So our job is to really protect that as much as possible. When we're unable to protect it, as I mentioned, a whole cascade of really bad things can happen. And this was a really interesting study looking at sleep deprivation as an oxidative stressor, where the sleep deprivation actually through, there's the cascade, which I'll actually show in a few other slides ahead, initiates this oxidative stress. And what that does is it increases the presence of inflammatory biomarkers or inflammatory mediators within the central nervous system and systemically as well, which then compromises brain development. And then that compromised brain development leads to impairments in learning and memory, reduced synaptic plasticity, and one of the outcomes that has been identified is anxiety and cognitive impairment. Another experience that can cause sleep deprivation is pain. And think about yourselves, when you've hurt yourself or you're not feeling well, how that really undermines your sleep. Oftentimes when we don't feel well, we find that we are sleepy and we spend more time in sleep, but sometimes the quality of that sleep can be hindered. And the same thing for our patients. And, for the units or the patients that require sedation, it can be even more challenging to understand and assess their sleep because, again, their eyes may be closed and their face may be relaxed, but we're not sure they sleep. And if you look at the literature around the use of different narcotic agents and sleep architecture, the narcotics actually impair, just like wine or alcohol impairs the quality of our sleep, these different opiates and other types of medications can impair the quality of sleep and actually disrupt the development of the sleep architecture. Here, Banan et al. Talk about that sleep is the predominant behavioral state in infants and is involved in maturation and development of the brain. That pain interferes with the quantity and the quality, but sleep deprivation, now here's the catch-22, pain will interfere with the quantity and quality, but the more sleep deprived you become, the more sensitive you become to pain. So it's this, it just keeps feeding itself, and fear and anxiety often have a negative impact on the quality of sleep. And so the emotional experience of these individuals, which can easily be mitigated by kangaroo care, parental presence, and all that kind of stuff, also feeds into compromising and undermining sleep health and sleep quality. This was, again, a really cool, I thought, nerdy image that really just showed you all of the different impacts of sleep restriction or sleep deprivation. These are all at the central nervous system level, the neuronal level. All of these different neurochemicals, neuropeptides, neuromediators, neurotransmitters that are impacted when there's not enough sleep. Because again, the job of sleep is to clean out the brain, reorganize, reprocess, restore central nervous system and body function. And so when you're not getting enough sleep, there's a price to be paid. And this just really, for me, delineates the detail of what's really undermining healthy brain development and why we're ending up with these types of impairments around learning, memory, and cognition. There were also some really interesting work out there looking at the relationship between sleep-wake states and feeding progression. And we know this in full-term healthy individuals that they sleep, they wake up, they eat, they go back to sleep. They wake up and they eat, go back to sleep. I mean, as they mature over time, they go to sleep, they wake up, they eat, and then they spend a little bit of social time, then they go back to sleep. And these cycles kind of evolve, but Pak et al. Really uncovered a really interesting connection between the idea of sleep and feeding. And it's really regarding this connection between the development of sleep-wake states and infants' emerging skills to attain oral feeding. So again, remember how I said the sleep-wake state is a reflection of brain maturation and integrity? Well, feeding is a very complex skill that requires maturation, right? You can't teach maturation. It just evolves over time. And so when you see the sleep-wake cycles really falling into place and maturing, often what these guys have discovered is that there's a concomitant progression, maturation of the infant's feeding skills. However, when you don't see this maturing sleep-wake cycling development, you will also see feeding disorganization and that sort of thing. And what they recommended is, when you do see that, kind of take a step back, protect the infant's sleep, and then try again. It was just really, really interesting study. And I know many of you guys are super nerds about the feeding situation. So again, you know, infants, it was just a really cool graphic to kind of highlight. The delayed trajectory is the top solid bar, and the broken up one is, you know, kind of the typical progression. So infants with delayed feeding progression showed a slower rate of development in active and quiet sleep during the day and tended to be awake more often during the night. Sleep and wake state development has a pivotal role in brain plasticity, which is the ability of the brain to change its structure and function in response to the environment, right? Adapt. The POC study revealed that the slower development in active and quiet sleep, as well as the interruptions of sleep during the night, seem to affect the infant's ability to regulate feeding in response to challenges that arise in the process of attaining full oral feedings. And so the different challenges are the coordination, right? Suck, swallow, and breathe. Just, you know, developing a good seal, and all of these other types of things. So, you know, being aware of this relationship really helps you come up with some evidence-based strategies that are going to really help the patient, right? And then this was me super nerding out on this to just kind of show the relationship between the day and the night with the developmental trajectory for waking, for active sleep, and for quiet sleep. So the development can be associated with the infant's emerging skills to attain full oral feedings over longer periods of time during hospitalization. Their findings highlighted the importance of providing developmentally appropriate care consistently throughout the hospitalization, which can promote the normal development of sleep and wake, and then concomitantly improve feeding outcomes. The recommendations were that infants who demonstrate abnormal feeding or abnormal or delayed patterns of sleep and wake states, or delays in their feeding progression, need more protection from the environment to support the sleep-wake state development as well as feeding. And so it's a holistic approach, you know. So during feeding, you want to have reduced stressors and diversions to the infant so that they can really focus on the task at hand. And you employ those same strategies to protect sleep, right? Minimize the noise and the distractions in the environment so you can really protect the sleep of the infant. So we're really, you know, in an exciting time here in neonatology where we're learning so much about sleep, and we can take this new knowledge, and apply it to our clinical practice in service to the patients, how we support the families in crisis, but also ourselves, how we optimize our own health and wellness to bring our A game to our work, but also to our lives, right? To ourselves and our families. So really this idea of sleep protection, although I do focus on the NICU, it impacts every aspect of our lives. And we really need to be mindful and figure out what kind of strategies we need to employ to really protect and preserve sleep. It's crucial. Thank you so very much. And I hope to see you guys all when we do our final module, looking at, I forget, but you'll see it soon. All right. Bye, guys.